Thank you so much for that very kind introduction. Today, I will be speaking about trauma-informed and culturally responsive care for HIV and STBBIs in Indigenous communities. Um, I will also repeat some of the things that Logan said, but I work in Treaty 4 and 6. I'm situated on the territories of the Nihiwak, the Anishinaabeg, the Dakota, Lakota, Nakota, and the homeland of the Métis-Michif Nations. I'm Anishinaabe Ojibwe from Chaging First Nation in Ontario, and an active citizen of my late husband's community, which is Ataka Cree Nation, where my son is also a member. I'm Turtle Clan, and that means I carry the teachings and patience and wisdom and responsibility while also serving as a natural teacher and negotiator for my people, guiding others with balance and care. I'm a professor in Ed Psych and Counseling and the CIHR Research Chair in Applied Public Health, Indigenous Wellness, and Health Equity, and a co-author, not the creator of the CRF, the framework that I'm presenting. It was created by the 74 First Nations communities, but I'm the author that took it into a theoretical model for the elders. So today I would like to talk to you about understanding the impact of colonialism on Indigenous health. So thank you for joining this presentation and on understanding the ongoing impact of colonialism, especially in relation to HIV and sexually transmitted and bloodborne infections. Today we will explore how colonialism continues to affect the health of Indigenous peoples and communities, and how culturally responsive, strengths-based, and trauma-informed care can support healing and resilience. So the purpose of this talk is to examine the legacy that colonialism has created, the deep-seated and lasting health disparities, and we aim to show how we can address these challenges. I will focus on actionable steps that healthcare providers can take to integrate Indigenous knowledge and advocate for health solutions. Sometimes I refer to myself as a we because I actually work in a team. I've never done any of this work in solo and would never be able to. So that's why I say we a lot. Okay. So in Indigenous communities in Saskatchewan face a disproportionate burden of HIV and sexually transmitted diseases driven by historical trauma, systemic inequities, and gaps in healthcare access. The Medicine Chest Clause of the Treaty 6 obligates the federal government to ensure the health and well-being of Indigenous peoples, but this commitment is clearly not being met. The medicine chest is a very important clause for us. And so if you don't know anything about it or you want to know more, my friend, Dr. Gerald Bone, just wrote a book that came out this year. She's a settler doctor. She just retired and she wrote the book Medicine Chest, where she does a deeper dive into that. And I would be willing to do a further presentation on that, even with her, if people were interested. I think the statistics in Saskatchewan are beyond alarming. Saskatchewan has the highest rates of new HIV cases in Canada at 19 per 100,000 people, compared to the national average of 4.7. I think that's low. I think 19 is way lower than we really have. And that's one of the things I hope the Saskatchewan Hub is able to finally get their hands around and help support real data coming forward with HIV in this province. Only 77% of HIV cases in Saskatchewan are diagnosed, meaning many individuals remain undiagnosed and untreated, and largely that is the homeless population. So we have a really significant issue here. Of those diagnosed, only 65% are virally suppressed, reflecting significant gaps in treatment and care. Injection drug use is a major driver of the crisis, accounting for 65% of new HIV cases annually. And syphilis rates have surged by over 400% since 2016. Actually, I think the latest might even be 800%. So it's more than double the national average. Indigenous peoples, while representing less than 5%, that's pretty alarming. 5% of Saskatchewan's population account for 11% of new HIV diagnoses, further underscoring the disproportionate impact on these communities. So there's a call to action. This data reveals an urgent and egregious healthcare failure in the province, particularly in addressing the needs of Indigenous peoples. Immediate steps must be taken to ensure equitable, culturally appropriate, and accessible healthcare services in alignment with Treaty 6 obligations. The alarming rise in injection drug use, accounting for so many new cases and syphilis increases since 2016, demands urgent attention. These statistics reflect our health crisis and systemic failure to fulfill treaty obligations. The Medicine Chest Clause, meant to safeguard the health of Indigenous peoples, is clearly not being honored in this context. And this data calls for immediate action to ensure equitable, culturally appropriate, and accessible healthcare for all, particularly those who have been marginalized historically. This is called The Umbrella of Resilience. It's Monique Gray's work. Does she she's got great work, but I don't think she's a faculty. I think she just really does this out of her counseling practice. So she doesn't necessarily promote herself academically like we would. And so this hasn't necessarily been updated. But I started using this when my grandmother said to me that it's not always about residential schools and that I personally had a responsibility to speak to that we aren't just here because of residential schools, that there were policies and practices and things that occurred from 1492 when Cristobal Colon came to the present day that are still affecting us. And so my cookum wants to make sure that you understand that we're not just here because of residential schools, that we're here because of the missionary schools, the Indian Act, the churches agreements. There's all kinds of accords that have happened. So every time I look at this, I see something different. And when I see something different, I know that I personally have an obligation to go learn more about it. So this is a great resource if you ever want to understand. And I really hope someday that someone updates this, but it's her work, so I'll wait for her to take that up. So going back to colonialism's impact on health, colonial policies have left a lasting impact on Indigenous health with historic events such as residential schools and the pass system, creating mistrust of the healthcare institutions. Forced assimilation in residential schools and abuse led to intergenerational trauma that continues to affect Indigenous peoples today. Normally, if I were in a classroom or something, I would ask how many people know what the pass system is because most don't. And again, going back to what my grandmother said about not just saying this is all residential school, the pass system was actually a restrictive policy, like a high school pass in Canada from the late 19th century to the early 20th century, requiring First Nations people to obtain permission from an Indian agent to leave the reserve, severely limiting their freedom and their time of movement. So if the Indian agent said you can't go into town to get groceries, you can't go into town to get groceries. And so many people do not know that was a thing that we had to experience. So to rebuild trust, healthcare providers must recognize this history and its continued effect on Indigenous health outcomes. And so I think this is key, especially for like new physicians coming from foreign physicians coming in. And when they come here, they learn the same thing that everyone else learns from Canada. So you see the even that someone may come from a community and when they get here, they learn the same thing everyone else does, and then they start buying into that mindset as well. Colonialism and adverse childhood experiences. I'm sure most people in this audience know about the adverse childhood experiences study. If you don't, I highly recommend that you check it out. It's an important study. It's one of the largest that has ever happened with the N of thousands, and it really looks at the role of adverse childhood experiences on adult onset diseases and health. So colonization, trauma is connected to health, and colonization introduced systemic racism and policies that disrupted Indigenous ways of life, leading to increased rates of mental health challenges such as PTSD and substance abuse. The ACE framework demonstrates how early childhood trauma, such as abuse and neglect, leads to long-term health challenges, increasing vulnerability to diseases like HIV and STBBIs. So I work in a lot of areas. I don't just work in HIV. I work in diabetes area. I work in maternal care. And so I'll just share one policy with you that just to give an example of how a policy could disrupt our way of life. There are evacuation policies for pregnant Indigenous mothers. So if you live in a First Nation or Northern community, you are likely to be evacuated out of your community several weeks before birth, bring you into the city alone. They don't evacuate your whole family. They don't evacuate your partner. They evacuate the mother only. Maybe she speaks the language, maybe she speaks English, maybe she doesn't, but regardless, she's forced to leave community and birth on her own in an urban environment. And that decontextualization of birth out of community has been single-handedly one of the most destructive things I think our communities have ever experienced. It emaciated our midwives and our doulas. It emaciated our protocols and our practices. So that's just one policy. And if you look at my cookum's umbrella, there's all of those policies. So we really have to think about how these deep-rooted policies cause uh, crucial disruptions, and that we need to have trauma-informed care that acknowledges the past while empowering the communities to heal. It's not enough to just be a kind person. We really do need to understand why people are where they are so that we can help them move forward. The Cultural Responsiveness Framework was actually created by a memorandum of understanding between Health Canada, the Federation of Sovereign Indigenous Nations in Saskatchewan, and the Ministry of Health. And they had a renewal of that a couple of years ago. And when they did the first one, they started doing engagement with the 74 First Nations communities, not the Métis communities. I want to be very clear that this engagement was with First Nations. And they came up with this framework of how they thought that healthcare could be integrated with Indigenous ways of knowing. And it was written in a very lay, accessible language. Then the communities brought that to me and asked me and Shawnee and Pete, Dr. Pete, to enliven this into a theoretical model. That was a very interesting process, but now we do have the cultural responsiveness framework. And so this framework in Saskatchewan, at least, we ask and we insist that anyone doing any work with governance, policy, health, education, that they use this framework. And I'll give you the scaffold because you can use it as well. So the CRF integrates Indigenous knowledge into healthcare, promoting self-determination and culturally safe care. It's a decolonizing approach that shifts power back to Indigenous communities, empowering them to take control of their health systems. And healthcare providers can foster Indigenous-led programs and engage communities in designing healthcare strategies that reflect their needs and values. So this is, my opinion, the best way that we can think about the same way how to make some of these changes. So it offers us a framework for healing. It offers us a model that harmonizes Indigenous knowledge and Western medicine to create culturally safe care that acknowledges historical trauma while focusing on cultural empowerment and revitalization. So for providers, healthcare providers, co-designing care with Indigenous communities ensures that the care is provided as respectful, culturally relevant, and effective in promoting well-being. Part of the CRF, so I came up with this diagram or the scaffold of the CRF. Um, and I really like it because it just gives you a nice little picture of what it looks like. So when you think about using this scaffold, there's three strategic directions. And the first is to think about restoring community-based health and wellness systems. So when we do any work, we think about what did we do traditionally on our own before we were disrupted? What kind of systems do we have in place? Sweat lodges, other kinds of ceremonies are also the things that we look at the possibility of restoring. And I've worked with communities who lost those practices. So we would have to go to another community and ask them to bring that practice back into a community. So some of the work I do is just helping restore practices or finding people who have the old knowledge that can bring that training into the community for restoration. The second thing we do with the framework is establish that middle ground for engagement between mainstream systems and Indigenous worldviews. This is part of the two-eyed seeing. The idea of two-eyed seeing as well is to create that ethical space where these two entities can coexist and where we position Indigenous ways first. So in that ethical circle, that sacred space, which could be a ceremony, it could be a meeting, it could be whatever you have, that you position. And I like this because it doesn't have to be Indigenous, but your community could be a school, your community could be anything. But whenever we do research or we work with another, we should always position the other first. So what that means is if we are working with a First Nation, and the first day we work with them, they want us to be in ceremony all day, then we go into ceremony all day. And if they want us to start working the second day, then that's what we do. If they want to open in a Christian prayer, we open in a Christian prayer. So this is how the model locally adapts to the community it's working with. And that's what I love about it the most. And the third strategic direction of this model is to transform service delivery. How do we transform service delivery to be culturally responsive? And it's all wrapped up in a package of being trauma-informed, strengths-based, culturally grounded, and spiritually grounded. So again, spiritually grounded by enacting the practices of the local people that you're working with. And so I'll just expand on the middle ground a little bit more because I find that this is the most difficult part. It sounds really easy. Get the groups together and just start harmonizing, getting along. Two-eyed seeing is great because it's the concept that brings together the strengths of both the Indigenous knowledge and I always say the evidence-based Western practices, not just any old Western practices. And this approach allows us to respect both worldviews, creating a path forward that benefits both perspectives. But I'll say that, I don't know if I say this later on, but I'll just say it now. I took up the concept of harmonizing. It's not enough to put the two together. It's not enough to make them interact. I always say, even if it's evidence-based, if it doesn't harmonize with us culturally, we throw it out. If it doesn't harmonize, if it doesn't work, it's out. And that way it gives us the out of, even though it has evidence behind it, it doesn't always mean it's going to work for Indigenous people. So that harmonization concept came from my former PhD student who's now graduated, Dr. Carrie LaValle, and our work with her work on addictions and elders. Okay. I'm just going to say this about two-eyed seeing again. It can't hurt to hear this stuff more than one time. Again, two-eyed seeing is the concept that brings together those two worldviews to harmonize, and the ethical space is the place in which we try to work out the issues that we have. What I find about the ethical space is that even though we're trying to engage two-eyed seeing, 99.9% of the time, when I've worked with trying to find an ethical space with non-Indigenous institutions or agencies or healthcare, whatever, that they always want to lead. I've never really seen a positionality where they come at the table ready to have Indigenous people lead. In fact, that's like a mind blow for most people that one, we're capable of leading, that, I'm called on by the health authorities, I'm called on by lots of entities and agencies. And so many times they'll say, oh, we need to create a mental health framework for Indigenous people. Well, we have one. We have one that's well studied, well published, by Thunderbird Partnership Foundation, which is an Indigenous organization. So we're not in absentia of knowledge, but it's always assumed that we are. It's assumed that we don't have Indigenous scholars. It's assumed that we don't have our own ways. And I think it's time that people start doing thorough lit reviews before they start coming forward and saying that they know what's best for us. And many of our universities are extraordinarily guilty of this. So trauma-informed strengths-based perspective really says to deliver effective trauma-informed care, we must first acknowledge the long-lasting impacts of colonization on Indigenous communities. Rather than focusing on the deficits, we need to shift to a strengths-based approach that recognizes resilience and community empowerment. So years ago, I was giving a talk on HIV, and a physician stood up and he said, you're saying to be strengths-based. So what's strengths-based about HIV? I mean, like, what's positive about that? And I said, well, considering where you work in Saskatoon and your population that you work with, the fact that you have an HIV positive addicted individual showing up to your office daily for care is a resiliency. That is a massive win. And the fact that you don't see that is a bit troubling because these people every day are doing things that are resilient. And we need to recognize that. So if you don't see that, if you don't understand what strengths look like, try to train yourself to start speaking in a strengths-based way. So start thinking about what a strengths-based perspective might look like. Even though I'm strengths-based, I often have to reframe my approach, my questioning on my research. There's always deficit coming through because that's how we're trained. Trauma responses and Indigenous healing practices. Trauma affects individuals on many levels: emotional, spiritual, mental, physical. It often manifests as hypervigilance, emotional numbing, or even dissociation. Indigenous healing practices, such as ceremonies and land-based healing, help to restore balance and foster healing by addressing trauma holistically. So it's complementary to Western medicine often. Although I would say that one of the things my medicine man used to say, deceased Edwin Tutusis, is don't come to me in stage 4 cancer asking for a miracle. Our medicines aren't necessarily miracles. They are protective mechanisms that harmonize and work alongside. When we enact our medicines or our ways of knowing, we have responsibilities to behave a certain way around that medicine, to respect that medicine. If we're picking it ourselves, to pick it properly, to know how to pick it, to make our offering before we pick it. There's a process. We can't just abuse our medicines either. So it's really important for people to understand that our way, our traditional way, has been disconnected from us. And so many people think that we can just go pick medicine and put it in a hospital in a room, and that's okay. We have strict protocols around this. I remember one time my husband and I went to go get sweetgrass from someone on the reserve, and he went in to make the offering, which was not financial, it was a gift. And he came out and he said, we can't get our sweetgrass here anymore. And I said, why? And he said, they have alcohol all over the place. So we won't even get our medicines if they're near alcohol or drugs. So really thinking about the role of medicine and that it plays part of the reason it's so successful and powerful is because it teaches us how to behave as well. It teaches us how to respect our body and to respect other people's bodies. And so there's a whole bunch of teachings that go along with this way of life. It's not just one ceremony is going to cure us. It's a way of life and a way of knowing. So trauma and intergenerational impact. I was gonna lost my slide here. Okay, I think this is, sorry. So intergenerational trauma is passed down across the generations. It affects not just those who directly experience colonial violence, but their descendants as well. I think this is a really important thing because people say, why don't they just get over it? It was a long time ago. It's because when your parents are kidnapped and put in a school and never allowed to be parented and never allowed to learn how to parent, then when they come out and they have children, all they really know how to do is reenact what they experienced and what they know. So we have to really understand that people are not choosing this, that this is a way that has been taught and instilled in them from residential school. And so we have to learn how to break these cycles. The impact on health is we have higher rates of PTSD, substance abuse, anxiety, depression, all of that are much higher with Indigenous people. And that leads us to being more vulnerable to HIV and other STBBIs. So substance abuse linked to trauma is a significant risk factor. And a social determinant of health alone is colonialism. So we have to really start to recognize colonization as a social determinant of health. I did mention the ACE already, but I want to just talk about it again because I think it's very important. The ACE framework shows how childhood trauma, including neglect and abuse, leads to long-term health issues such as chronic diseases and mental health and other risky behaviors. So, if you had a lot of trauma in your childhood, the chances of you getting diabetes, heart disease, all these adult onset diseases is very, very high. If you have a score on the ACE of a 6 or higher, you will most likely will manifest in these chronic diseases in adulthood. And it can be disrupted, but then it has to be disrupted properly with proper, sleep, nutrition, movement, all the basic things that many people don't do or have access to. There's a unique vulnerability for Indigenous women. Indigenous women make up nearly 50% of HIV cases among Indigenous peoples, despite being the smaller percentage of the population. And this vulnerability, again, is driven by historical trauma, gender-based violence, and systemic inequities that increase risk factors, including substance use and limited access to healthcare. And limited access can be as much as First Nations communities often do not have healthcare systems. They might have a visiting nurse, they might have a visiting doctor, but they do not have fully functioning healthcare systems. They must come out and go to the community for a larger point of care. The other issue is access to transportation. So many people cannot leave the reserve to get into the cities for care. And let's be real, so many people in the city can't access care because they don't have transportation, whether that's taxi, whether it's walkable, or whether they have their own vehicle. So this is a chronic problem, whether it's on reserve or off. It just may manifest and look a little bit differently depending on where that is. There are so many barriers to healthcare access. Mistrust, as I've talked about already, the stigma and discrimination. If you have HIV, maybe you're uncomfortable. You don't want to be outed. You don't want to know. On our reserves, many of us don't want to use the medical system if there is one because auntie's going to tell so and so what's going on in your business, and we just don't want that risk. There's a lot of geographic isolation with First Nations communities. And so some healthcare provider solutions are actually to create culturally safe spaces to address mistrust and discrimination and to collaborate with Indigenous communities to improve healthcare access for Indigenous women. And I'm working on the same issue on the maternal care side as well. So, and you might think, oh, just get taxis, taxis will help. But then we have an issue with taxi cab drivers assaulting Indigenous women and driving them out of town and raping and molesting them. So this is not just like as easy as, getting a taxi. This is really a systemic, deep-seated issue of a lack of access to care. In addition, there's violence and mistrust in the medical community. I really saw this during COVID. Again, I'm not a specific researcher in a certain disease. I kind of bounce around. I'm community led. And during COVID, I was called to help develop a model of care for the vaccine for Indigenous people. And that's when I really started to see how the past does really affect our ability to engage in the healthcare system, especially for the elders, because that's who went first for the vaccine. So we had to work with the elders. And when I first started trying to figure out how we're going to get the elders to engage in the COVID vaccine, I started to learn about some of these studies that are here. And the one I didn't list, I think, because I accidentally took it out, but the most important one was that the TB vaccine in Fort Capel, that's what was in the memory of the elders. There was a TB vaccine, and maybe I did mention it, I'm not sure. Is it this slide? There was a TB vaccine in Fort Capel where they went in and they used the Indigenous community as guinea pigs and they vaccinated them. And at the same time, a lot of those children were dying of starvation. And so what it really said was that, that Indigenous people are disposable, that they are nothing but guinea pigs for medical practices to try to see if things work. And at the end of the day, rather than try to eradicate TB with Indigenous people, they just left them there and they let the children starve who were also injected with these vaccines. So it just left an overall bad taste in our elders' mouth from this region. So when we were trying to get them to consider being the first to be vaccinated with the COVID vaccine, this is what we had to encounter. Not only that, but nutritional experiments between 1942 and 52 on Indigenous children in residential schools. They were subjected to unethical nutrition experiments. They were denied adequate nutrition. They were denied medical care. They were studied by nurses, doctors, epidemiologists. Imagine these little children in like their little undergarments. Well, we'll just look at them here. This is what's going on, right? They're these little children just being used and abused by these medical care people, um, which just contributes to so much distrust that we have for the system now. This isn't over. We just had a study come out a few years ago on the forced sterilization of Indigenous women. My mother was one of them, 27 years old. She had a complete hysterectomy. So we suffer for being this marginalized group that Canada has access to and can pretty much get away with doing whatever they want to us. So how do we address trauma through cultural responsiveness? The CRF helps to build trust by offering culturally safe, trauma-informed care that acknowledges past trauma and honors Indigenous identity. And of course, if it uses that middle ground and we can get into that Western Indigenous conversation and work through these things together, that's the best approach. A strengths-based approach highlights the resiliencies and encourages healing through cultural revitalization. So I think that those are the best ways that we can get through trying to address cultural responsiveness, is really like looking at it through trauma-informed care. Indigenous resilience through healing, Indigenous resistance and healing. One of the things that we have is the power of cultural revitalization. My son, his dad passed away in 2019. So in 2018, we lost my husband's brother, who was a cultural male. My husband was cultural. Then in 2020, we lost another one to COVID, 21, grandpa, and just the whole family was emaciated. And the access to culture for our family here in the city has been really altered. And it's been really hard to find ceremonies when we're used to ceremonying with our family. So one of the things that I noticed when my son started a new school here that had a very strong Indigenous component, is that they have a boys drum group and he would sit with the drum, but he wouldn't sing. And then later on he would mouth singing and he would pick up the drumstick and hit the drum. And then at the end of the year, he was singing, he's singing strong. And I watched him change as the culture found him. I watched him become more confident and proud of who he was. I watched him go from like only mouthing words to like singing a full-on lead in a drum. And I know that even though we haven't been able to find the culture for us, that spirit's finding him and I'm watching it heal him. That's what I mean about the culture, the revitalization of our traditional practices. So part of my research chair in Indigenous wellness, I hired a woman who's going to start doing regalia making for youth, trying to get them back into dancing. Not only is dancing good for their bodies, because 1 in 6 Aboriginal children has diabetes, so it's good for their health, it's physical movement. So there's all kinds of things about the culture that are preventive, that are protective. And so just trying to restore those practices is, I think, the way. I'd like to just share some examples of community-led initiatives because that to me is really where the change will occur. There are very few, but there are a few physicians in Saskatchewan who will go out to First Nations communities and really try to make the model of care in alignment with what the communities need. And we have really good success and we see some great things happening. So some examples are land-based programs focusing on traditional activities like hunting, fishing, gardening, helping reconnect individuals with their heritage and fostering well-being, and traditional medicine and wellness centers. So we created a lodge on our campus to try to have culturally responsive therapeutic services available, and programs for two-spirited and LGBTQ youth, LGBTQ people, plus people, have health initiatives, which I'm going to share. This is not my initiative. I want to be really clear because we do have a mother's bundle. So in a lot of the work we do, my team, we have a bundle. We don't have an HIV bundle because there's already one, and I think they did a beautiful job with this bundle. Anyone in Canada who is First Nations or Métis can reach out to this medicine bundle program and receive a bundle. And I did receive one so that I could look at it, manipulate it, and see what's in it. And this is a picture of it on the bottom. It comes with several traditional medicines. Now, I think if you're in BC and you're local, you can pick out the medicines that go in your bundle, but when it's shipped to you, obviously you can't. It also comes with, so it usually comes with like sage, sweetgrass, tobacco, cedar, lavender, Labrador tea or muskeg tea, bear grease. And it comes with sexual relationship supplies, sexual health relationship supplies, as well as HIV test kits. And I had the bundle on my kitchen table. And at the time, my son came home and he was 11 and he was looking at it. And I didn't think anything of it. And then he took out some of the brochures and he said, "Oh," and those brochures were very enlightening. Let's say that my son knows a lot about safe sex now, and he hasn't been sexually active, but oh my goodness, those brochures really taught us a lot. I was really questioning my parenting for a moment, but I thought, he said to me, "Mom, it's better I know because who knew you would take a condom off after doing it with this person before doing it with that person and put on a new one." And I thought, okay, well, we've made some progress in your sexual education. So it's a really good, well done bundle. And it comes with a prayer mat. So it's just a really nice thing. So those are things that I think when you partner with a community or with other groups, if it's urban, that you can really start to come up with some ideas that could be really useful and successful. So resilience through Indigenous-led health. It has a community empowerment. Indigenous-led health programs empower communities to take control of their healthcare systems, blending traditional knowledge with trauma-informed care. This approach fosters resilience and improves health outcomes for conditions such as HIV and STBBIs. There are some trauma-informed care and cultural safety principles. Trauma-informed care must prioritize safety, empowerment, and trustworthiness. Cultural safety is equally important to ensuring that Indigenous knowledge is respected and that healthcare providers engage in self-reflection to reduce power imbalances. I know that cultural safety isn't always the best. Cultural responsiveness doesn't always work. Cultural humility is out there. We've got all different types of cultural stuff. What I would just say is like try to just get to know them all. They all have something to offer and they're all lacking. They all have gaps. So we just try to do the best we can, which leads me to the path forward. So healthcare providers and Indigenous communities must work together to co-create culturally safe healthcare environments that address HIV and STBBIs. Centering Indigenous knowledge in healthcare decisions is essential for fostering healing and creating equitable systems. Addressing mistrust and stigma is a key important factor for creating situations where people feel comfortable enough to go to their healthcare provider. My husband passed away from something preventable and treatable, but he passed away because when he suggested to the healthcare provider that he was using traditional medicine, rather than respect that and say, you know what, we noticed that maybe it's not working. Maybe we could try to do some Western intervention as well. She said something like, "Your way doesn't work. That's just nonsense. You need to do X." And he disengaged in care and didn't tell me and ended up dying. So one of my life goals is to ensure that no one dies for something preventable and treatable, especially because someone's an asshole at the front desk. Like that's just not necessary. So really, I think we need to create some knowledge systems. And I feel sometimes the unions interfere because there's no incentive for unions to encourage change in the front lines of these professional places. So we have some work to do on understanding, but I really think that using holistic care models by integrating traditional healing and biomedical medicines is the best way forward. And establishing outreach programs and practices for people to have access to these things would be the best approach that we could do. We need to overcome healthcare hesitancy. And as long as we don't address the history and address the past, I tried during COVID to get the local health authorities to apologize for the past, to acknowledge it so that maybe we would get some trust for the COVID vaccine, but that was not happening and it never happened. So I don't know how we're going to get there if we can't acknowledge the past. Again, the truth and reconciliation, the first part of it is truth. If we can't speak the truth and get it out, we can't metabolize the emotion that we're stuck with. We can't metabolize the experience. So speaking and hearing our truths is as important as having an intervention. And often the intervention won't work if we haven't been able to speak the truth and if we haven't been able to co-create it as well. So trauma-informed strategies used to increase different confidences in different medical processes, I think is what we really need to look at. And we need to build equity through collaboration. Obviously, we don't have enough Indigenous healthcare providers yet on our own. So we need to work in allyship with non-Indigenous healthcare providers and systems. We need to create accountability structures. My research chair is a partnership with the health authority here. But I still have to be critical of the health authority. And one of the things that I am very critical of are when health authorities or other entities want to say, how are we doing with the TRC calls to action? Let's evaluate ourselves and see how we're doing. That is not your job. Your job is for Indigenous people to evaluate you and see how you're doing. And this is again going back to that middle ground where Indigenous people should be leading. No, non-Indigenous people are leading. It is not for an organization to evaluate itself when it comes to Indigenous work. It is for Indigenous people, First Nations and Métis people to be the ones to say that this is working or not working. I cannot seem to drill that into these systems and these institutions into their head. They don't get it. And that's consistently where we have the biggest rub is right there and that point. Because if we're in that ethical space and you don't let Indigenous people lead and you lead, then you fail yet again. What you create for us does not work. It does not get taken up. And there we are, once again, in the same status quo that we've always been in, or sometimes even worse. We all have a responsibility to advocate for systemic change, to prioritize Indigenous-led health programs, to foster self-determination, and to commit to ongoing change. We have actionable steps for healthcare providers that they can do, ensure that healthcare environments are welcoming, respectful, culturally relevant. Many are not, most are not. It's a fact. I couldn't get my husband to go into a dentist's office. I really tried. He was slapped by a dentist in his youth, and that trauma stayed with him. And I even had a dentist who like worked with me to get him into the chair, and he just panicked and left. And that was a dentist who was really, really trying and still failed. So even if we try all these things, we've got so much historical trauma to overcome that it's going to take work to get us out of our fear of these systems so that we can get in there for care. The other thing is to use active listening and cultural learning, which with 15-minute appointments with our physicians is not often easy to do. And to use trauma-informed communication. Always invite people to participate and ask them if this is okay. One of the things that I thought was so amazing when my late husband was evacuated, medevac to Edmonton, was the care that he got in the ICU. They spoke to him, he was in a coma, and they told him everything. We're going to wipe your face. We're going to do this. They were so kind to his comatose body. And that's when I realized too that it's actually not as much about the culture. It's about kindness. It's about respect and dignity. So they really didn't do anything culturally appropriate, but they were kind and compassionate. And so I think that is as important as the culture in relation to being in those environments where you're scared and you're unsure of what's happening. So in conclusion, I will just say that the key takeaways are that Indigenous communities face disproportionate impacts from HIV and STBBIs due to historical trauma, and that trauma-informed and culturally safe care is essential to rebuild trust and improve health outcomes. And that the call to action is that healthcare providers must commit to creating culturally safe, trauma-informed environments. They must engage with Indigenous knowledge and collaborate with communities to ensure equitable care, to take steps to reduce stigma and foster trust through patient-centered care. And the next steps are to integrate these practices into daily care routines and to advocate for systemic changes to support Indigenous-led health initiatives. I have a final slide. I'm hoping that I'll send this to, I think this gets posted for you all. This is just tools. Some of them may not be relevant, but there's some things in here that might support your work. So I'll leave that as a gift. And with that, I will close for questions.